Hi, I'm Dr. Philip McMillan. Thank you for joining me. As today I'm making a discussion with regards to excess deaths, that problem that seems to not quite go away. Oops. Yes, sorry about that. The problem that doesn't seem to be going away, so to speak. And no matter which way it's taken, it's it only stays with us. And it's a question that needs to be answered. And so I'm going to be talking about this particular paper, Excess Mortality in England Post COVID 19 Pandemic, Implications for Secondary Prevention. And this, it's an article, a commentary actually in the Lancet that is going to be published. So it's kind of pre published before in December, but it's actually published in January 2024. And it raises some important points that we have to reflect on. From my perspective, I've always been focused on autoimmunity around COVID 19. And so excess deaths in the context of the pandemic is not a surprise to me. And more importantly, excess deaths I don't think are going to stop unless we very, very quickly try and understand the mechanisms and search for reasons to mitigate it. So, as I said, we'll just go through this particular paper just so that you can see what it's about. Here we have this excess mortality in England post COVID 19 pandemic implications for secondary prevention. As you can see here, it is January 2024. This is volume 16. It's a Lancet Regional Health from Europe. And this is more of a commentary than an actual paper. But it's looking at valuable data around the ONS statistics from the United Kingdom. As usual, when I look at these papers, I tend to look at any declarations of interest. And in this case, there are some. The one of the authors is a partner, Royal Society of Public Health, and he has had some personal fees from some of the pharmaceutical companies outside of the submitted work. It doesn't mean that necessarily what he's saying is compromised, because actually what he's saying is very, very important. So, although I recognize that in truth, I have overlooked that point because I think that on balance, the information is likely to be quite sound. And so, within the context of this particular situation, I'll be trying to look in a bit more detail as to what exactly this commentary was saying. So let's go back to the article here. And so this is it here. And I've highlighted a few things just so that it's easier for me to be able to see them. So, as we said, these are all based in the United Kingdom. So, some from Imperial College, Newport, again, London, and this is Exeter Medical School. And so, these are experts from different parts of the United Kingdom. And so they have highlighted that many countries, including the UK, have continued to experience an apparent excess deaths long after the peaks associated with the COVID 19 pandemic. And in highlighted here, and they've gotten their data from the UK Office of National Statistics, 7.2% or 44,000 more deaths registered in the UK in 2022 based on the 5 year average prior to this, excluding 2020. So they were looking at a 5 year average between about 2019 to 2040, I'd say about 2014. And they've noticed that this persisted into 2023. So it was 7.2% in 2022. And in 2023, at the 6 month mark, it was 8.6% higher. That's 28,000 more deaths registered. And so, technically, at this rate, we're looking at potentially around 56,000 more deaths compared to 2022, which was at 44. This is serious stuff. And as I said, this is not going to just simply disappear. This needs to be looked at. in great detail. So I'm very appreciative of the fact that they are highlighting this. I've been looking at this since early 2022 when I saw the flag in Euromomo, and I thought this is not right, especially in the younger age groups. And so this stood out as being critical. We needed to look at this. And in truth, we may be 2 years too late to be acknowledging this. This is really critical because with disease, if you don't intervene early, very often by the time you try and intervene, it could be potentially too late. So, going back to the paper here, again, we have here. Now, they've pointed out that the causes of these excess deaths are likely to be multiple and could include direct effects of COVID 19 infection, acute pressures on the NHS acute services, resulting in poorer outcomes from episodes of acute illness, disruption of chronic disease detection and management. And I agree with all of those reasons. But I think what I'm disappointed about is the fact that they haven't addressed in that cohort of explanations, they did not address the elephant in the room. Now, the elephant in the room is not going anywhere, and it requires us to be able to scientifically look at it objectively and try and address what this could be about. You have to remember, I'll give you an example from, in my view, a clinical perspective. Imagine that we gave vitamin D. Now, vitamin D is something I think actually should be done at population level. Imagine that we gave vitamin D across the whole population. Okay. And after we did this, we found that excess deaths rose. Now, you may say, well, vitamin D can't be causing excess deaths, so it can't be relevant. No, that's not what you do. You say, hold on, that's not right. We need to try and make sure the fact that we have used vitamin D at population level could not be a mechanism for contributing to excess deaths. Suppose it wasn't the vitamin D, suppose it was something in the formulation, suppose it was a timing, suppose it was an interaction with something else. You don't know. What you don't do is exclude vitamin D. And that's exactly what I think has been done here because the elephant in the room has not been included. I think that's a failure of this. As much as I appreciate what they have done, they just have not been objective enough with regards to that. And as you can see here, I'll take you back to it. They included COVID 19 infection. Yep. Pressures on the system. Yep. Poorer outcomes from people who had severe COVID 19. Yep. Disruption from chronic disease detection and management. Absolutely, yes. But you did not include the elephant in the room. That's a problem in my view. And I think this is part of the reason why we're seeing trust being eroded across the first world because it is a reasonable question. You just need to exclude it. You just need to make sure that is not a part. And that's what I said from early 2022. You cannot ignore it. Ignoring it will only fuel problems. You have to address it. Now, I am very appreciative in the UK that they are able to look at this kind of data and look at it, study it, and take it for what it is. I wish we had that kind of approach in New Zealand, where they have very valuable data and they are just not sharing it. Why? I don't know. Because it should, in everybody's mind, confirm that they did the right thing if they are so sure. But anyway, that's a different point. Let's get back to this here. Now, one of the things that stood out for me again here was that when they looked at the excess deaths for all causes, it was greatest in the 50 to 64 age group, which was 15% higher than expected. Now, this is what I highlighted 11% higher for the 20 to 49 and the less than 25-year-olds. Now, the reason why I highlighted this one is because in this cohort, it is much less likely that these things are relevant because younger people tend to be fitter. They tend to be able to tolerate even if they miss their doctor's appointment for a year, they'll get sick, but they won't die. And that's different. So if you were seeing an 11% increase in that age group, you really have to question what could be the mechanism. Now, I think that this is where it comes down to the crunch, because younger people, as I said, don't usually just die, they get sick. And then when they get sick, you have to try and fix them to make them get better. But when you look at the paper again, and I highlighted another section here, in terms of the causes, several causes, including cardiovascular disease, showed a relatively excess greater increase. So all cardiovascular diseases, 12%. For heart failure, it was 20%. For ischemic heart disease, it was 15%. Liver disease, 19%. So this is important in terms of highlighting some of the major causes. But when you look further down here, deaths involving cardiovascular diseases were 33% higher than expected. While on specific cardiovascular diseases, deaths involving ischemic heart diseases were 44% higher, cerebrovascular disease 40% higher, and heart failure 39% higher. Now, this is where I take it back to the younger people again. As I said, younger people tend to get sick unless they just drop dead or they're hit by a bus. They usually get sick first because their bodies are usually resilient unless they have underlying comorbidities. But in the context of cardiovascular disease, sudden death, where it's an arrhythmia, that's different. You have no time. And so that's where people would die in their sleep. They would die on a football field. They could die swimming. It's all kinds of things where you have excess pressure on the heart and then an unusual arrhythmia that could lead to death. That's what I think is really, really important and could highlight why younger people are more affected in terms of the numbers. 11% increase in the less than 49 age group. Here's the final point that I'd want to make here. So this is looking at the place of death between the 3rd of June 2022 to the 30th of June 2023. There were 22% more deaths in private homes than expected, compared to 10% in hospitals, but there were no excess deaths in care homes. Now, again, you have to break this down and you have to think carefully about this. 22% excess deaths at home. My question again is not across all age groups. I want to know the under 49s. How many under 49s died at home? Because as I said, younger people are usually more resilient. Unless it was suicide, which could happen, but in the house, a younger person with no comorbidities almost invariably is a clot on the lung, a bleed on the brain, or a cardiac event. That's where that very important statistic would be very valuable. What was interesting in that in care homes, you didn't have any significant increase, but you had a 10% more in hospitals. What it suggests, in my view, is that the patients who were unwell in care homes were probably transferred to hospitals when they're unwell, and those patients then died in hospital. That then led to potentially the 10% more in hospital. But this 22% increase in private homes doesn't make any sense because usually you can have people who die at home in terms of if they've got cancer, end stage disease. It's very difficult for families to manage them at home. So actually, it's easier very often to take them into a care home and the family support there. But to do it at home is very difficult emotionally and practically. So that 22% at home, I think, could be the key to understanding these statistics. Because if you break it down and you find that in the less than 49-year-olds, that there's a significant increase in that group dying at home, I think that's an absolutely a red flag. And as I said before, if you look back across here, 11% higher for this group, 25, technically less than 49 years old. that's a concern. So, what percentage of that increase is in that 22% that's in private homes? That's the kind of question that we need to ask and we try and need to understand. As I said, this is not going to disappear. I don't know who is advising politicians internationally, but I'm just warning everybody that the pattern needs to be addressed. When it comes to mitigating disease like hypertension, hypertension is silent. It only presents with cardiac disease, heart disease, kidney disease, brain disease 15 to 20 years after. You can't afford that kind of thing to happen. This is why we check blood pressures for people, even though they have no symptoms. It could be exactly the same pattern that we're looking at here. So we need to look for the mechanism. We need to critically deal with the elephant in the room, really important, and nobody should walk away from this elephant because it's important to clarify. Just if it's only just to reassure the public, you definitely have to deal with the elephant in the room. But these are difficult times. These are times when our leaders may be worried about their position. But my hope is that we are at a stage where we don't have a situation where we don't deal with issues because people are concerned about their personal circumstance. No, this is a time where lives are at stake and we have to find solutions. I'll make one final point about this as to where my concern is. When we look at this here, the one thing that stands out to me is that in terms of the cardiovascular diseases, for ischemic heart disease, that's where they have the blood vessels are blocked. We can fix that. So if we look for it, we can fix it and deal with it. But when it comes to heart failure, 39% higher, I'm telling you this. If heart failure is presenting at the onset, which is one of the things I was saying, 39%, at that stage, we have no tools to fix the heart failure. We can try and scrape the edges with some medication, but we are not able to resolve that heart failure. And what it will mean is that significant heart failure, aggressively progressing heart failure, is going to shorten someone's life very, very significantly with limited mitigation factors. We need answers. I'm very glad the scientific community is starting to ask the important questions. But sadly, we have a long way to go before we find solutions that could hopefully mitigate this storm surge of excess deaths. Have a great evening.